Hi everyone, hope you're all doing good. I just recorded this just in case there were any issues with connection because the internet where I am is pretty poor. So I want to talk today about cutaneous lymphoma. And I'm definitely not an expert in cutaneous lymphoma, and this might be a bit basic for some people, but really I just wanted to talk a bit about cutaneous lymphoma classification and T cell lymphoma classification, and perhaps how to work up cutaneous T cell lymphoma using one case to illustrate this. I'll do a few slides on Sézary syndrome, and then perhaps if there's time, two cases of a rarer presentation of cutaneous lymphoma. So lymphoma is a cancer of the lymphocyte, and the type of lymphocytes that we see are T cells and B cells, which of course are part of the adaptive immune response, and they're natural killer cells, part of the innate immune response. And also there are lymphoid precursor cells, which can produce dendritic cells, which can be involved in both innate and adaptive immunity. When you classify lymphoma, we of course generally often divide them into Hodgkin's and non-Hodgkin's lymphoma. And then in the bucket of non-Hodgkin's lymphoma, it can either be a systemic lymphoma or a primary cutaneous lymphoma, where the lymphocytic proliferation starts in the skin. So if you get a skin biopsy that states that it is a lymphoma, you should always consider whether this could be a primary cutaneous lymphoma or a systemic lymphoma that has spread to the skin. You can then divide primary cutaneous lymphomas up into T cells, and you might also include natural killer cell lymphomas in this category, a B cell lymphoma, or the rare blastic plasmacytoid dendritic cell neoplasm. And T cell lymphomas account for about 2/3 of all primary cutaneous lymphomas. So how do we distinguish what type of lymphoma it is? So there are CD markers on the immune cells, and you can consider these as flags on the surface of lymphocytes, and these can be identified by using immunohistochemical stains. So CD20 tends to be the marker for B cells, and CD3 is a marker for T cells. And T cells and B cells then both have multiple other markers on their cell surface that can help differentiate them further. We'll just talk about the T cell CD markers only today. And here's an example of a few T cell markers. So CD2, CD3, CD5, and CD7 are called pan T cell markers, meaning they are present on most mature T cells. However, you can lose expression of some of these markers when you develop a lymphoma. I also want to mention the T cell receptor, which is part of T cells that bind to antigens and activates the immune system. T cells all have slightly different receptors, and this obviously allows the immune system to identify all of the many different antigens. However, if you have a clone of a T cell, they will all have exactly the same receptor. So by doing T cell gene rearrangement studies, you are able to identify a clone, and this will be reported on the report as a monoclonal peak. So we can then further divide T cell lymphomas into the category of classic cutaneous T cell lymphoma, then the CD30 positive lymphoproliferative diseases, and then there are a whole range of rare subtypes of T cell lymphoma. If we look at the classic cutaneous T cell lymphoma bucket, the main one, of course, is mycosis fungoides. And you can get classic mycosis fungoides, or you can get it divided in subcategories. So you can get folliculotrophic mycosis fungoides, where the proliferation tends to have an affinity down the hair follicle. You can get something called granulomatous slack skin and pagetoid reticulosis. I won't really be able to go into these in much detail today. And then in the other option of classic CTCL, you have Sézary syndrome. Then looking at the other T cell lymphomas, so you can get the CD30 positive lymphoproliferative diseases. These can be divided into anaplastic large cell lymphoma and lymphomatoid papulosis. And then again, I won't go into these today, but you can get lots of rare subtypes of other T cell lymphomas. So you can get the CD8 positive aggressive epidermotrophic T cell lymphoma. You can get a natural killer T cell lymphoma nasal type. You can get a gamma delta T cell lymphoma and a CD4 positive small medium pleomorphic T cell lymphoproliferative diseases. And then there are others. One of note is you can get a subcutaneous panniculitis like T cell lymphoma. And this can sometimes be confused with other types of panniculitis, for instance, lupus panniculitis. And so this is always a category to consider in people that have a prolonged panniculitis of which the definitive cause has not been found. So how do we deal with cutaneous lymphoma? So I suppose when dealing with cutaneous lymphoma, you need to have a systematic approach. Of course, you want to make the correct diagnosis. You then want to make sure you stage it correctly, and then you want to formulate a treatment plan. So when you're considering a lymphoma, you want to do a very good history and skin exam. So for instance, if the patient has had patches and plaques potentially in the bathing suit distribution over a period of years, you might be thinking mycosis fungoides. If they have erythroderma and lymphadenopathy, you might be thinking Sézary syndrome. Or if they have these plum-colored discrete nodules on the head and neck or on the legs, you might be considering a B-cell lymphoma. You then probably will want to do, for a lot of them, you might do routine bloods and you might include a blood film and an LDH. And then you will do a skin biopsy and you'll be looking at a few things. In general, you'll just, the pathologist will be looking at general H&E histopathology, look at the morphology of the cells and the pattern of the cells. They'll then do immunohistochemistry and use the different stains mentioned before to identify different CD markers. And then they'll do TC or gene rearrangement, as mentioned before, to identify a clone. So with regards, I'll just mention a case here. I don't actually have images of the case, and it's nothing really interesting in the case, but it's just in general the case as an illustrative purpose. So I'll present a 79-year-old man. He presented back in 2013 with a few months' history of a rash affecting his buttocks, groin, abdomen, and lower limbs. And in the notes, it had been described as multiple circular areas of different sizes, with the widest being about 4 centimeters. It said that some areas were patches and some areas were plaques, and it affected about 20% of the body surface area, and there was no lymphadenopathy, and it hadn't improved in primary care with topical Umivate ointment. And as I mentioned, I don't actually have the slides from the patient, but for instance here, the image on the left, you might see an erythematous patch, and the skin almost looks a bit wrinkled, or almost what we call cigarette paper atrophy. And then this is probably not as pronounced as, sorry, this is more pronounced in the case I'm discussing, but think of kind of patches, and some areas maybe plaques, covering about 20% of the body surface area. So the patient in question had bloods which were normal, including LDH, and they did a skin biopsy. And I'll show some photos later of biopsies we might see, but it was reported as a band-like infiltrate in the superficial dermis, composed mainly of lymphoid cells and histiocytes. And then there is a patchy infiltrate of medium-sized lymphoid cells with a slightly irregular nuclei confined to the basal aspect of the epidermis. And the picture here looked like mycosis fungoides. So to confirm this, they did immunohistochemistry, and the majority of the lymphoid cells expressed CD3, CD4, CD5, but there was loss of the pan-T cell marker CD7, and this was supportive of a diagnosis of mycosis fungoides. And then they did a skin biopsy, and they did do T cell receptor gene rearrangement, and this showed a monoclonal peak. So again, it was quite easy and supportive of a diagnosis of mycosis fungoides. So we have the diagnosis, and now we want to move on to staging. And staging is quite similar for mycosis fungoides and Sézary syndrome, whereas for different types of cutaneous lymphoma, it's different. So you want to do an exam, and you want to work out, is it a patch, is it a plaque, is it tumorous, and then you want to work out the body surface area. You want to do a lymph node examination, and if there's anything to palpate, you want to do a biopsy. You might also want to do imaging in certain cases if it might look advanced, and you can consider a CT and or a PET scan. And then if there's any suspicion of Sézary syndrome, you want to look at the blood. So you might do a blood film, in which case you might see Sézary cells on the blood film, which are basically atypical lymphocytic cells. And you then will do flow cytometry. And with this mechanism, you can look at the CD3, CD4, and CD8 counts, and also importantly, the CD4, CD8 ratio. And then also on blood, you can do TCR gene rearrangement, which will identify a clone. So in general, you might want to do a CT neck, chest, abdomen, and pelvis in all patients with CTCL and cutaneous B-cell lymphoma, except in certain cases. So you do not do it in early mycosis fungoides, which is stage 1A, 1B, which I'll mention in a few minutes, or another type of indolent T-cell lymphoma called lymphomatoid papulosis. So this is just a staging for mycosis fungoides and Sézary syndrome. So you divide it into the tumor. So T1 is limited patch or plaque disease, less than 10% of the body surface area. T2 is generalized patch or plaque disease, greater than 10% of the body surface area. T3 is if they're tumors, so if they're, obviously more raised and tumor-like, and T4 is generalized erythroderma. Then you will do the lymph node assessment. So it's quite complicated, but just very simply, N0 means no abnormal lymph node involvement. N1 means clinically enlarged lymph nodes greater than 1.5 centimeters, but pathology actually doesn't show a definitive abnormal lymphocyte collection. N2 is small clusters of abnormal cells in the lymph nodes, and N3 is the lymph node is completely replaced with lymphoma cells. And then metastasis is easy, M0 no visceral involvement, M1 there is visceral involvement. And then we'll move on to blood, and you do this if you're suspicious for Sézary syndrome, and you can quantify the amount of abnormal lymphocytes in the blood. So B0 is that there's no circulating Sézary cells, or actually that there's less than 5% of the total lymphocytes are abnormal cells. B1 is that the burden is greater than 5% of the peripheral blood lymphocytes. And then B2 means there's a very high blood tumor burden, and that's greater than 1,000 Sézary cells with a positive clone. So in our gentleman, he had T2 stage because he had patch or plaque disease greater than 10% of body surface area, but it's quite simple. He had no nose involvement, no metastasis, no blood involvement, and he was diagnosed as stage 1B. So with regards to mycosis fungoides, complete cure is rarely, if ever, achieved, and the aim is to improve symptoms, cosmetic appearances, and health-related quality of life. And a pivotal clinical trial actually demonstrated that aggressive systemic treatment of early stage disease using systemic chemotherapy does not alter overall survival, and therefore skin-directed therapy is the mainstay for early disease, whereas systemic treatment is usually reserved for more extensive disease. Essentially, so what is skin-directed therapies? Again, I'm not going to go into these in huge detail, but you might consider topical steroids as a first line. So you might consider a super potent topical steroid on the body, such as Dermavate. However, it usually recurs with cessation, so you might need to consider giving maintenance, so maybe a topical steroid on the weekends. There are then different types of topical treatments used for lymphomas. So there's a nitrogen mustard called meclorethamine and carmostine, and these are both DNA alkylating agents. They can be quite useful. You need to let the patient know that they can burn, they can itch, and they can irritate when used. You can also use a topical retinoid called bexarotene, and this can be considered an early stage CTCL who are refractory or who have not tolerated the other topical treatments. And really, with the bexarotene, the overall response rate is about 63%, with a complete clinical response of 21% in one study. If all these topical treatments really aren't keeping it at bay, you might consider narrowband UVB for patch disease, but due to its limited penetration, it may not be as good for plaque disease. So PUVA is better for plaque disease as it penetrates deeper into the dermis. But again, like in other treatments, you really need to limit lifelong sessions to about 200 sessions. Mycosis fungoides is a very radiosensitive tumor, so it can be used for isolated localized skin disease, or it can also be used in palliation if they're very bulky tumor nodules. And then there's something called total skin electron beam therapy. And this is used for people with diffuse plaque involvement, which is refractory to the other skin-directed therapies. Essentially, it's radiation treatment involving the whole entire surface of the skin. And patients will get a course of about 2 to 4 days a week for about 8 to 10 weeks. And sorry, I don't have much more details on the effectiveness of these treatments. So let's just go back to our case now. From 2014 to 2020, our patient was quite well controlled with just a combination of skin-directed therapy. He really just used topical Dermavate when it flared and kept on maintenance. Whenever it flared up or got a bit more progressive, he used narrowband UVB. So we used them in 2014, 15, and 17 with a good response. He did do a course of PUVA, but he had some side effects with that, so it was incomplete. However, when he was seen in 2020, his skin was actually quite almost clear, and then he would occasionally get patches that would come up, and he'd use emollients and Dermavate for flares. Then in 2022, he had a significant flare of his skin, and he had a new symptom of intractable itch. Actually, a lot of it was found to be fungal infection in the end, which responded to antifungals. But he did have two nodular lesions on his right forearm and the right pectoralis major. Importantly, he had no generalized lymphadenopathy. So these actually are images from the patient, and as you can see, this is more of a nodular lesion, that really patches or plaques if you were to feel it. So an excision on the biopsy was performed on this leader, and it showed a nodular infiltrate deep to the superficial dermis, and interestingly, there was no epidermotropism. But a PCR was done on the skin biopsy, and it showed a clonal T cell population. He also had a nodule excised from the chest, and it showed quite similar features, with immunohistochemistry being supportive of a diagnosis of mycosis fungoides. Interestingly, in the lesion excised from the chest, this did show something called large cell transformation of mycosis fungoides. So what do we do now? The picture is slightly changed. So we was discussed at the lymphoma MDT. This is now in Glasgow, where I was working previously. And they suggested a CT chest, abdomen, and pelvic. Back to what you consider. So, what do you consider if the lymphoma's progressed? So, again, I won't go into huge detail, but systemic therapy is usually reserved for patients with advanced or relapsed disease, or disease that is refractory to skin-directed therapy. It is palliative rather than curative, so you need to let the patient know that nothing really is going to cure this lymphoma, but it might help control the symptoms, and as such can be quite useful. So if you look at this slide, you might consider, one consideration is single agent chemotherapy, such as methotrexate, or the other ones listed here in red. But the general responses are generally not as good as compared to some of the other cutaneous lymphomas that we see. You can also consider a combination of chemotherapy, such as CHOP or VIAP-B, but which they tend to have a better response rate, so the skin improves, but actual survival rates remain unchanged, and the toxicity can be quite considerable with these. There are a range of various other kind of biologics and immunologic therapies, such as interferon alpha, bexarotene, and then there are even some newer biologics, so adamtizumab, which is an anti-CD52 treatment, and brentuximab, which targets CD30, can be quite useful in certain situations. And then finally, there's something called extracorporeal photopheresis. Basically, this is a systemic form of PUVA, which can be used in erythrodermic patients. So basically, the blood is kind of removed from the patient, and it's exposed to, basically the patient's given a Sorolin, and then the blood is removed from the body, and it's exposed to UVA, and then it's reinfused to the patient, and this can be quite useful. So with regards to our patient, he was seen in the lymphoma clinic. It was felt that given he'd tried multiple courses of UVB that wasn't working, he would get a trial of methotrexate. And CT chest, abdomen, and pelvis was pending when he was discussed. And with regards to methotrexate, in mycosis fungoides, it tends to have a response rate of 76%, with a 5-year survival at 71% in one study. So we went on to have a CT thorax, abdomen, pelvis, and unfortunately, he was found to have a hypodense area in the liver. It was indeterminate, but represented a metastasis. It could represent a metastasis. And then the MRI liver was done, and it was found that it could represent a malignant lesion, and it could be consistent with a lymphoma, but it was not entirely specific. He had some issues getting the liver biopsy, as he had many cardiac comorbidities and had recent complex angioplasty, and they did a repeat liver MRI instead, and the liver lesion was growing. Now, I actually won't discuss much more about this patient. It was more administrative purpose, how to work out things, but he went on to have a liver biopsy, and I think the last I heard it actually was a hepatocellular carcinoma, which really complicated things. So I'm not sure actually what they decided on for treatment for him in the end. I'll just briefly go through mycosis fungoides summary. So it accounts for about 50% of all primary cutaneous lymphomas. It typically affects older adults. It usually has an indolent course with a slow progression over years or even decades. And generally, the progression is from patch-like lesions to plaque-like lesions, and then it turns to tumours. And the initial lesions tend to have a predilection for the buttocks and some protected areas, and this is called the Bayesian skill distribution. In later stages of the disease, the lymph nodes and the visceral organs may become involved. And this is a general image of what you might see. So you can get, in the early stages, you can get the lymphoid cells actually going up into the epidermis, and this is called epidermotropism. And this still seems quite confined to the lower levels of the epidermis, although you might see higher cells higher up in the epidermis. And then when you do CD3 staining, you can see these positive lymphoid cells. Some are present in the dermis, and some of the atypical cells are present in the epidermis. Then, as the tumor progresses, you can get and it becomes more almost tumorous. You then will get these dense lymphoid aggregates present throughout the dermis. And the prognosis is dependent on stage. So the 10-year survival for limited patch plaque disease is about 97 to 98%. However, if they've got histologically documented lymph node involvement, this drops 20%. And there are per prognostic indicators. One is that if they have lymph node involvement with effacement of the lymph nodes, I have put in bold their visceral involvement, although thankfully this patient likely did not have visceral involvement with regards to lymphoma. Or in the patient's case, transformation into a large T cell lymphoma can implicate that it's a worse prognosis. So I thought I had a few slides on Sézary syndrome. I might go back to them at the end. But essentially, this is a more rare lymphoma now. So I'd like to report a 62-year-old man. He had background of working as of TB, and he also had aspergillus, and he worked as an asbestos remover most of his life, smoked about 20 per day. He presented with 2-year history of slow-growing, firm and tender lumps on his right shin, and he also had noticed some other lesions across his legs and arms, but was unsure how long they'd been present for. He had also developed fatigue, lethargy, and quite significant weight loss over the prior 6 months. And he had a CT chest abdo-pelvis performed by his GP quite recently prior to us seeing him, which showed progression of his lung fibrosis in the chest with small sub-centimeter inguinal lymph nodes bilaterally, which appeared reactive from the imaging. So these were the tumours that were seen. As you can see, they're quite striking. He had plum-coloured nodule, which is quite large on his right shin, and quite a thickened plaque on the left shin. And then you can see on the left calf, he had very thick plaque or tumour on the left calf, and another kind of plum-coloured lesion on the right leg. You can probably appreciate from the images he was quite cachectic. And again, my face is blocking out the area on the left arm, but he also had a plaque on the left arm. He had a biopsy done, incisional biopsy, and this showed a real diffuse, tightly packed dermal infiltrate. It actually extended down to the subcutis and to the muscle as well. And these were quite uniform, small cells with a dense nuclei. Staining was done on it and it was positive for CD123, 4, CD303, and TCL1. Find them. So yeah, I won't really go into Sézary syndrome, but I suppose people often wonder about kind of what is the blood classification. So Sézary syndrome, as we know, we often see a triad of erythroderma, generalized lymphadenopathy, and then you might see neoplastic T cells called Sézary cells in the skin, the lymph nodes, and the peripheral blood. And when you're looking at it, it can sometimes be a diagnosis of sometimes these erythroderma patients might have a very severe inflammatory cells. And so when you do their biopsies, they'll have lots of lymphocytes seen in the biopsy, and might often have some lymphocytes seen in the blood. So it can be difficult to work out if it's Sézary syndrome. So the biopsy will often show features very similar to mycosis fungoides, and sometimes it might be difficult to even differentiate it from it on H&E alone. So as a clinical and histological presentation may be non-specific, you really need to look for blood involvement. And you really want to see if you can demonstrate a clone of a neoplastic T cell in the skin and the blood. So when you're looking at the blood, you want to do an absolute Sézary count. And greater than 1,000 cells per millimeter cubed in the peripheral blood is part of the classification. Then you want to demonstrate immunophenotypical abnormalities, and this can be true one or the other. So you might see an expanded CD4 T cell population, which will result in a CD4 CD8 ratio count of greater than 10, or might see aberrant expression of the pan T cell markers. So you might get loss of CD2, 3, 4, 5, 7, or CD26. And then finally, you want to be able to demonstrate a T cell clone in the peripheral blood by molecular cytogenetic methods. So I just thought I'd mention that very briefly, but I'll finish my talk now. Thank you. Um, so um, so I'll just skip to case three, which is quite similar. He's a 76-year-old man known to hematology with a background in myelodysplasia for many years, which has been monitored. However, he was referred to dermatology by them as he had a 6 to 8 week history of new skin lesions, which were not painful or non-tender, and he didn't think they'd really significantly progressed since they first developed. As you can see, he almost had quite a lot of bruise-like lesions present on his chest. However, if you look on the arms, you can almost see these violaceous, almost again, yeah, purplish colored lesions. And if you were to palpate them, they felt quite deep and quite firm. And again, further biopsy, maybe the infiltrate wasn't quite as tightly packed or deep, but again, you saw a monomorphic appearing infiltrate of small, tightly packed cells. And immunophenotype was again positive for CD4, CD123, and TCL1. So the diagnosis in both cases here were something called blastic plasmacytoid dendritic cell neoplasm. So plasmacytoid dendritic cells, they're rare types of immune cells, and they secrete, specific to them, they secrete large amounts of type 1 interferon. They tend to circulate in the blood, and they can often be found in the peripheral lymphoid organs as well. And they originate from bone marrow hematopoietic stem cells, and interestingly, they can be of either myeloid or lymphoid derivation. You can get cancer of these cells, particularly in the skin, and this is called blastic plasmacytoid dendritic cell neoplasm. And it did have other names that you might see if you're reading papers from the past. So it was formerly known as blastic natural killer cell lymphoma and CD4 positive, CD56 positive hematodermic neoplasm. And these are essentially rare but clinically aggressive neoplasms derived from the non-activated precursors of plasmacytoid dendritic. I'm sorry, I was kind of prepping a few more slides for Sézary syndrome. So let's just see if I can. So the skin often presents as isolated or disseminated bruise-like lesions, that which can often be described as erythematous to purplish papules, plaques, or tumors with heterogeneous size. There is no preferred anatomic area, and if they're just isolated areas, you often get a progression-free survival of 23 months. But if you have eruptive lesions and multiple lesions, almost like both our cases, the progression-free survival is about 9 months. Rarely it can affect the mucous membranes. When you do histopathology, the cells are medium-sized, they show immature chromatin, and they resemble lymphoblasts or myeloblasts. And you often get a diffuse monomorphous infiltrate of these cells. The skin, so usually the dermis is massively infiltrated in both as in our cases, with extension to the subcutaneous fat, and the epidermis and the adnexae are generally spared. And as I mentioned as well, you often get lymph node and bone marrow involvement as well, and peripheral blood can be affected too. And the markers to remember are actually quite easy. So they often include the classic triad, and you can think 1, 2, 3, 4, 5, 6. So CD123, CD4, CD56. And you also can get a positivity for something called TCL1. And it will often be negative for B cell lineage. So it'll be negative for CD19 and 20, be negative for T cell lineage, CD3, and it'll be negative for myeloid cell lineage, which is myeloperoxidase. And then essentially, unfortunately, these are often inherently resistant to standard chemotherapy, and the responses are mostly transient. And overall, unfortunately, patients have a very poor outcome with a median overall survival of about 1 year. Chemotherapy with intensive induction regimes can be used, but again, this can be very difficult on the patients, and often patients tend to be quite elderly and quite frail. So only patients who undergo allogenic stem cell transplant seem to have a prolonged survival. And in some cases, they have overall survival rates of about 75 to 80% at 3 to 4 years. but unfortunately, most patients that have this diagnosis are not able to tolerate this. And then there is a new FDA approved treatment called tagraxofusp or something along those lines. And this targets CD123 expressing cells. And in a single arm, so small trial of about 13 patients, it showed a complete response rate of about 54% with follow up of 11.5 months. So this looks very promising, but more studies and research needs to be done. And so I think, Reid, that's kind of all I was going to talk about.